How on earth do you organize something as incredibly complex and mysterious as the human mind, especially when it's in distress? Well, that's pretty much the fundamental challenge of psychiatry. In this explainer, we're going to unpack how the field tries to create some order from that chaos, all through diagnosis and classification.
Think about it for a second. We all feel sad, we all get anxious, we all experience stress. So where is that line? At what point does grieving the loss of a loved one, for instance, cross over into what a clinician would actually call a psychiatric disorder? Answering that exact question is the whole reason these classification systems exist, to try and draw that line as clearly and consistently as possible.
Okay, so before we can even begin to define a disorder, we have to wrestle with a much tougher word: normal. It sounds simple, right? But in mental health, it's an incredibly complex idea. So let's dive in and explore what normal might actually mean.
It turns out there isn't just one simple answer. You've got the medical model, which is pretty straightforward. If there's no disease, you're normal. Then there's the statistical model, which is all about the bell curve. What's most common is what's normal. But other models get a little more nuanced. The utopian model, for example, aims really high, saying normal is optimal functioning. The subjective model is much more personal. It's about whether you feel distressed. The big takeaway here is that psychiatrists don't just pick one. They kind of blend these ideas together to understand that normal isn't some fixed point, but a really dynamic, multifaceted concept.
All right, so with that complex idea of normal in our back pocket, how does the field actually go about drawing that clinical line and giving us a formal definition of a psychiatric disorder?
So, this is it. This is the formal definition, and you can tell every single word was chosen very carefully. Notice those key phrases: significant distress or disability. We're not talking about just feeling a little bit off. This is about a level of impairment that genuinely messes with your life. And the definition also has these crucial exclusions. It's not just behavior that society happens to dislike, and it's not an expected response to something awful. This is where that line in the sand is drawn.
Let's really pull this apart. First, subjective distress. The person is actually suffering. Second, objective disability. It's not just a feeling, it's actively getting in the way of their ability to function. Third, it has to point to some kind of dysfunction inside the person, whether that's behavioral, psychological, or biological. And finally, and this is so important, we'll say it again, having a conflict with society does not on its own equal a psychiatric disorder.
Okay, so we have these definitions in place. But how do clinicians all over the world apply them consistently? Well, they use these comprehensive rulebooks or classification systems. The goal is to create a common language, so a diagnosis made in one country means the exact same thing in another.
There are really two main players on the field here. The first is the ICD 10, which comes from the World Health Organization. This is the global standard, and it covers all diseases, not just mental ones. Then you have the DSM-5-TR from the American Psychiatric Association. This one is laser-focused exclusively on mental disorders, and, as you might guess, it's used mostly in the United States. These two are the major frameworks that guide diagnosis for clinicians everywhere.
But making a diagnosis isn't just about picking a label out of a book. The way it's done has evolved to be way more holistic. The goal now is to see the whole person, not just the collection of symptoms.
This is a really important shift in thinking. The old way was super rigid. It used this hierarchy where certain diagnoses could actually rule out others. The whole goal was to find one single primary diagnosis. But the modern approach recognizes something called comorbidity, which is just the simple fact that people can, and very often do, have more than one thing going on at the same time. This is so much more helpful because it makes sure that all of a patient's needs are actually seen and treated.
So, to get that holistic view, to get the full picture, modern psychiatry uses a tool called the multi-axial assessment. It's a system that evaluates a person across several different dimensions, or axes. It helps move beyond a single label to build a truly comprehensive profile.
Let's break these 5 axes down. Axis I, that's for the primary clinical diagnosis, something like major depression. Axis 2 is for those long-standing issues like personality disorders that kind of shape how a person interacts with the world. Axis 3 is absolutely crucial. It notes any general medical conditions. Why? Because something like a thyroid problem can look a lot like depression. Axis 4 looks at external factors, psychosocial and environmental problems like losing your job or not having a good support system. And finally, Axis 5 gives a score for the person's overall level of functioning. When you put them all together, you get this rich, multi-dimensional picture of a person, not just a diagnosis.
So, after all that, you might be asking, why? Why go through this whole complex process? Why does all this classification matter so much? Well, it really all boils down to three fundamental purposes that are the bedrock of the entire field.
First up, communication. It gives clinicians a shared language so they're all on the same page. Second, comprehension. Grouping similar syndromes together helps researchers investigate what's actually causing them. And third, prediction. A good diagnosis helps clinicians predict the likely course of a disorder and make much better decisions about treatment. At the end of the day, it's all about creating clarity, understanding, and foresight.
You see, these systems are based on observing syndromes, which are just clusters of symptoms. And that's because, for a lot of disorders, we don't yet know the precise biological cause. But that is changing, and it's changing fast. So the final question I want to leave you with is this. As neuroscience starts to uncover the deep mechanics of the brain, how are these rule books going to be rewritten? Are we going to move from classifying symptoms to classifying the underlying biology? The next chapter in this story, well, it's still being written.